We are ready to begin, and good morning and welcome to the Davies Use Case webinar being presented by Nebraska Medicine on moving the mark on ambulatory clinical quality measures. This is a Davies Award winning use case for the value of health IT. My name is Arnold Simmons and I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT and enable care delivery. So it's my pleasure to welcome our two speakers for today's webinar, Dr. Tanvir Hussain and Tammy Winterbourne. So I'm going to turn the presentation over to you all and welcome you to this presentation. Thank you.
As Arnold said, my name is Tammy Winterbourne, and I'm the Director of Clinical Effectiveness and Informatics here at Nebraska Medicine.
And my name is Tanvir Hussain. I'm a General Internist and Deputy Chief Quality and Outcomes Officer for Nebraska Medicine.
So we wanted to start today by telling you a little bit about our health system. So Nebraska Medicine is located in Omaha, Nebraska, and we're a $1.2 billion academic health system consisting of 2 hospitals, 1 academic medical center, and 1 community-based medical center, having more than 8,000 employees and over 50 specialties and 40 clinics as part of our health system. And speaking of our mission and our values, we really focus on our I Teach values, focusing on innovation, teamwork, excellence, accountability, courage, and healing. And these are things that we really thought paired well with the HIMSS Davies Award, and really, I think, represents what Nebraska Medicine stands for and why we chose to implement these use cases in our system. Our domains, this is what we really focus on at Nebraska Medicine, and as you can see, patient safety is at the center. All of our initiatives focus on patient safety, but we also have priorities surrounding value, culture, growth, and reputation. And our brand promise here at Nebraska Medicine is serious medicine and extraordinary care.
Our presentation, Moving the Mark on Ambulatory Clinical Quality Measures, demonstrates many of the ways in which our strategy, mission, and values come together. As many of you know, something transformative occurred in April of 2015. The way that healthcare providers are reimbursed increasingly focused on an examination of the quality of care that they deliver. So MACRA, the Medicare Access and CHIP Reauthorization Act, was bipartisan legislation passed in 2015, which tied performance on quality measures to reimbursement. And as most health systems and many of the individuals watching this webinar know, the performance year began this year, January 1, 2017, and our performance this year will affect our reimbursement in 2019. The implications of MACRA are significant, with -4% to +4% adjustments in reimbursement in the first year, but progressing up to nearly 10% within the next couple of years. So preparing processes and systems that are sustainable over the next several years was key to some of the considerations we delved into at Nebraska Medicine. So at our organization, we are actually participating in the Merit-Based Incentive Payment System, or MIP, and as you know, that's a system that continues to reimburse based on the volume of service, but at risk is a certain amount of percentage of reimbursement based on quality performance. We are moving or inching towards a shared savings model as well. So we're participating in a Track 1 Medicare Shared Savings Program. So as you know, that is an upside risk model only. So in our first performance year under MACRA, we're actually participating in something called the MIPS APM, which uses the quality measures from the Track 1 Medicare Shared Savings Program in the way that quality is measured under MIPS. Here, for those of you participating in any of the tracks of the Medicare Shared Savings Program, you'll notice that these are some quite familiar quality measures. These are the ones that we have actively built out and will elaborate on throughout the presentation today. You'll see they are focused on population health measures such as vaccination, screening for cancer, common diseases such as obesity and depression, high-risk behaviors such as tobacco use, and disease control, for example, diabetes and blood pressure. Now, it was humbling. Historically, our organization has monitored our performance on ambulatory quality measures through the PQRS system, as I know many of you have also been participating in, but that was a largely pay-for-reporting program. MACRA upped the ante, and we had to not only report, but really reflect on how we were performing. So the table here shows our performance in calendar year 2015 and early 20. Analyze what our strategy was going to be if we were going to succeed in a pay-for-performance program. So incidentally, the measures that we in green are the ones that we were above the academic mean in, and those are measures that actually we had best practice advisories built around, but those in red were areas that we certainly needed to make significant improvement on. And at the bottom, tobacco use, med-rec, and blood pressure control, we were at the academic mean. So in 2015, early 2016, if we were to figure out what our approximate national ranking would be percentile-wise, it was close to about 35th percentile, which would have put us in the penalty zone. As all of you know who have undertaken organization-wide changes or have tried to create systems and processes which you hope to affect providers and operational leaders and frontline staff and residents, know that it's really important to have a strong governing system. So for ambulatory quality, you'll see there highlighted in yellow, we have an ambulatory care committee, which actually is an enterprise-wide committee that oversees quality at all the ambulatory clinic sites, and it's one of the quality committees that reports up to our Patient Safety and Quality Steering Committee that reports up to the board and to the advisory board. So it's a multidisciplinary group of providers, physicians, clinicians, operational leaders, quality, and others, and we try to make sure that our ambulatory strategy aligns with our other quality committees. So that's a bit about our governance model. However, on a project like this, where there are upwards of 14 quality measures, which requires a careful look not only at the specifications, at the discrete data capture, and builds, and our electronic health record, which is EPIC, the Ambulatory Care Quality Committee felt it was really important to have a task force, people who would really do the heavy lifting. So the Ambulatory Care Quality Committee chartered the Quality Measure Task Force, which included, you'll see in the upper right-hand corner, what we've labeled CTO team. That's the Chief Transformation Officers team. So Tammy and I are both part of that team that includes IT, our electronic health record, quality, safety, performance improvement, clinical effectiveness. So we had representatives from our team on the task force. We had certainly clinicians from primary care and specialty care and operational leaders, which included executive directors and managers, and frontline staff, including were brought in on an ad hoc basis. So at times we had medical assistants and our care managers, as well as behavioral health. So depending on the measure, we had to bring people in. So this was sort of the structure and the people in which we worked through each of these quality measures. So this was going to culture change to go from pay for reporting to pay for performance, and really between the Ambulatory Care Quality Committee and our Quality Measure Task Force, we thought it was really critical to really understand what were some of the challenges and gaps and barriers we'd have to address at the front line. So we actually, here you'll see the methodology through which we went to do some of the initial identification of defining the problem and measuring the problem. So we held 15 focus groups, which comprised about 19 hours and over 100 physicians. We also did structured questionnaires and did a literature review. So what did these data show? So the focus group data showed that one of the reasons there might have been a gap in the performance is many of our frontline staff and providers actually didn't know much about pay-for-performance or value-based care or what the measure specifications required or what they needed to do. And so the opportunity for performance improvement was not necessarily a lack of motivation or that they didn't care. It's just they really didn't know what exactly they needed to do. And also, they did feel that there was a fear that having to address these quality measures would increase documentation burden, so we knew that we would have to take that on in our work. You'll see those themes were surfaced again in the questionnaires, where people had cited they don't necessarily have confidence in improving their performance because they've never had to do anything like this before, so they would need really powerful tools to help them do that. And certainly as we move forward, as Tammy will highlight, the implementation or leveraging health information technology really, we'd have to make sure that it made their job more efficient and easy and gave them control over the process. So hopefully as Tammy shows you some of the design, you'll see how some of those themes play out. So after we did a high-level sort of understanding of the strategy, we delved more into some of the particular tactical things we'd have to do in the build to satisfy the customer and make sure that they would adopt it. So one, as I'm sure all of you have struggled with nationally, we're struggling with this, is which measures do we want our organization to focus on? So because Medicaid comprises over approximately 50 to 53% of our patient population or our payer mix, we landed on going after the Track 1 Medicare Shared Savings Program, and we provided significant education around what those measures were, and then creating transparency around performance on those. So when we started this project, providers did not know how they were performing on each of these measures, and they didn't know which measures mattered. So making that clear was really important. And then not only providing a clear list of measures and how each individual provider is performing, but also then making it easy for the frontline staff to see where those gaps are, and helping them quickly and efficiently identify some of the options available to them in our system to close those gaps. When we first assessed the number of clicks that it might potentially take to address each of these measures, in totality, if I were to look in every place in the chart to see whether or not my patient has had all the 14 measures completed, that could potentially be upwards of 100 click. And as you can imagine, that is too time intensive for any single provider during a visit. So as you can appreciate, it's impossible really, I think, for any one person to do all of this. And so as we built out our technology and our processes and systems, it was really important for us to think about how do we ensure that there's alignment between all the people who are actually contributing to the care. So what role does our medical assistants have, and our nurse managers have, and nurse care coordinators have, and our advanced practice providers and faculty and residents? So we really had to think about that at front and create a collaborative process. And finally, of course, at the end of all the meaning, at the end of the day, what really matters here is that we're not just clicking and hitting boxes, but we're really using whatever technology we create around these measures to actually help disseminate best practice about how to improve population health. So we use, in our quality improvement work, the DMAIC model. So you'll see that define, measure, analyze, improve, control. And we've talked already a lot about defining the problem and how we were going to measure it. I went into a little about the analyze phase, where we did the focus groups and the surveys to understand providers' attitudes. But in addition to that, we did a lot of workflow analysis and worked with our clinicians to figure out for each of the measures what's actually best practice. Tammy will show you a lot of the technology and tools we created to provide transparency and how we leverage real-time decision support and created workflows that were collaborative across disciplines and professional roles. So broadly speaking, what did this 12-month calendar look like? First, which was a really critical starting point, is we really had to define and get alignment on what our pay for quality or pay for value priorities were. As you know, in the MACRA proposed rule for the first year, there's over close to 98 to 100 pages of measures, and that's just for Medicare, not to mention the Medicare Advantage plans and all the private payer plans. So really getting alignment around what are our key priorities was central to our success. And then getting agreement on how that would be measured and then therefore reported in real time, not only to providers but to managers and to the organization. And then really trying to simplify and create an efficient process by bringing all those potential gaps in one places in the chart that can be addressed by the provider or the care team in real time during the visit, and working together with between disciplines and professions to make sure that whatever work one person did was actually contributing globally to the way that our organization takes care of patients, so that we really create a culture of team-based care towards ambulatory quality and population health.
So as Dr. Hussain mentioned, it was really important that we took into consideration the voice of the customer. And something that we heard really was that this process needed to be hardwired to address the need to understand what each of the measures were and how we could ensure compliance. So as you can see on the left-hand side of the screen here, we outlined the clinical process, and then we created system tools outlined on the right side of your screen that supported each step in that process. And this process starts from the moment the patient arrives in the clinic, from the rooming staff puts that patient into the room and documents some standard information, and then to the physicians evaluating, and then follow up after the patient has left to ensure we have the right metrics and data to review for both physician and physician supervisors to ensure that we're meeting those metrics. So first we started with the visit navigator. And what you can see here is that rooming requirements at the point that the patient arrived and was being taken back as part of the rooming process were split into two sections. The first section is things that had to occur on every encounter. Things like vital signs, blood pressure, pulse, height, weight, chief complaint, reviewing their medications, and then there were things that had to be done on an annual visit. And so this was on the other half of the screen, so it made it very clear to the rooming staff which needed to be completed when. In addition to that, the team created rule-based banners, as you can see at the top of the screen, that highlighted in yellow when those annual measures were not complete. So things like nutrition screening, pneumococcal vaccine screening, other types of screening that could have occurred at other clinics in our health system. It made it clear that whoever was rooming this patient knew what had occurred in the reporting period and what needed to be complete in the reporting period. Also for the rooming staff, what was important for the voice of the customer was that the rooming staff worked to the best of their ability to support the physicians. We wanted them to be able to do as much as possible to allow the physicians, when they got into the room, to have all of the information they needed. So in the quality measures section of our Visit Navigator, we created quality measure alerts. These were reminders that were based on the regulatory metrics, and in this case, reminders that were within scope for the rooming staff to complete in certain parts of the task. So for the ones that you see on the screen here, it was to ensure that the depression screening was created or that the patient was screened for falls. Then the results of those would then go to the provider for further evaluation. Providers, there also is a quality measure section. So at the end of the visit, when they've completed all of their documentation and care for whatever the primary reason for visit was, the providers click the Check Quality Measures button. At that point in time, the system evaluates the 12 quality metrics that Dr. Hussain had mentioned earlier, and then sends alerts to the provider to say what was complete and what was incomplete. The providers get green check marks for things that were completed, and for things that were incomplete, they get not only reminders, but instructions on what steps to take next and follow-up actions that can occur right there within the alert. So in this case, the depression screening clearly shows the provider the information they need all in one place. And as Dr. Hussain mentioned, this information could previously be found by searching up to 100 clicks throughout the chart. So this automates that chart checking and reduces those clicks that are normally spent searching for information. In addition, it integrates best practice recommendations. So in the case of pneumococcal vaccination, it not only tells the provider that the pneumococcal vaccination is due, but it says which pneumococcal vaccination is due based on the rules that were approved by CMS. In addition, there's references to materials both from the CDC and to the CMS metrics themselves. So if providers aren't sure, they can not only look to the clinical information, but also to the regulatory metrics to see the details of the requirements. But as I stated before, the most important thing is that the actions are right there. They can order the pneumococcal vaccine right from within the alert and satisfy the regulatory metrics. As I stated, one of the things that we heard voice of the customer was that when they did something right, we often did not fire them alerts, but we didn't actually tell them that they had done it well. So one of the things that we heard from providers is that they wanted a green check. They wanted that check mark that said, yes, I did what I needed to do, and no further actions are required. So as part of this quality measure section, we not only have the alerts that tell them what needs to be done, but we also have a section that tells them what has already been satisfied. It really addresses that need for the green check mark. So if you've done everything that you need and you get 12 check marks because your patient qualified for all 12 measures, that's good news. And then a lot of times they will get some green check marks, some alerts, and then they know which ones have been addressed and which ones need to be addressed. Is that post-visit, providers didn't have a good way to know how they were doing on these metrics. Overall, how am I doing with all of my patients, not just that one individual patient? So dashboards were created specifically for providers where they could look at each of these metrics and evaluate their performance. In addition, on these dashboards, we created frequently asked questions and metric specifications. So again, if they had any questions about what was included in that metric or why they might be passing or failing, they could look in that information area. In addition, in each of these metrics, there's drill down opportunities so they can get all the way down to the patient level to see where they have areas for improvement. And as you can see this example, we color-coded them for them to know things that they were doing well on, and they could quickly visually see areas that they needed to spend a little more time addressing. In physician leaders, so medical directors of areas, chiefs and chairs, was I need to know how my physicians are doing as a group. So additional dashboards were created, and in this case, it's a little difficult to see on the screen, but by clinic, where you could look by clinic how all of the providers in that clinic were doing with regards to measure specification. The drill down functionality that existed on the personal provider dashboard also exists on the leader provider dashboard, and they can drill down to a level where they can evaluate all their physicians and identify if there's any outliers or if there's any trends or if any additional follow-up or training is needed for their team to ensure compliance with these metrics. So from the metrics, we really wanted to see one of the main concerns that we had from both providers and our rooming staff was that the additional work for the rooming staff was going to provide longer clinic visits, and it was going to take longer for the patients to be prepped before the provider could go in the room. So as part of our data evaluation, we not only documented how compliant we were with required documentation items, but how long it took to do that rooming process. So as I mentioned in the previous slides about our new navigator orientation, the required documentation, things like blood pressure, height, weight, was now more clear. It was clear on one side of the screen what needed to be recorded each visit, and it was clear on the other side of the screen what needed to be recorded annually. As you can see here, from the implementation of our project in June of 2016 through August of 2017, we saw a significant increase in compliance with that required documentation. It was much more clear what was required, and so that documentation is happening much more consistently. Interestingly enough, our rooming time did go up with initial implementation of the project. As people were learning and understanding how this documentation was to occur, we did see a slight increase in the average rooming time. But over time, we saw that decrease back to baseline. So in essence, we are getting better documentation with the same amount of time for rooming for these patients. The question we often get asked is that we have a button that allows providers and rooming staff that they have to press when they're ready to evaluate the patient. Interestingly, we recently have been asked if we could automate that, but what we needed to find out first was whether those tools were being utilized, whether the teams were really wanting those tools. And what we can see here is that over time, thousands and thousands of QMAs are being fired for these providers and this rooming staff in order to ensure compliance with these metrics. And as you can see, some of it is seasonal. So influenza, for example, one of the things that we've told these providers and rooming staff is that we on the back end will make sure that those QMAs are in alignment with the regulatory metrics. One of the philosophies of this decision support tool is that they need to consistently go to the quality measures section, consistently check the quality measures, and that on the back end, the system will stay up to date with all of the changes and all of the regulations and all of the measures. So we have a steering committee that is constantly updating these measures to ensure they're always in compliance with the changes. And all the provider needs to do is to continually check those quality measures, and in doing so, we'll have the appropriate actions there for them to take and follow up to be in compliance. And influenza is a good example. This only required certain seasons of the year, and so as you can see, the QMA fires during those seasons, and outside of those seasons it doesn't, and that is not something that the provider has to choose. They click check quality measures, and the system determines that for them.
It was really important for us to really provide feedback to the organization, our leadership, about whether or not their time investment in these new processes and tools were actually impacting care. So these are the same measures you saw at the very beginning of the presentation and our performance in 2015 and 2016. As I mentioned, at the end of 2015, our national percentile approximate across all measures was 35th percentile. Now we're surpassing over 70 to 75 percentile, putting us in that exceptional performance range. I want to draw your attention just to a couple of examples. You'll see, for example, colorectal cancer screening went up from about less than 20% to 45%. Pneumococcal vaccination across the organization reached nearly 60%. Breast cancer screening over 50%. And remember, this is ambulatory-wide, so includes primary care and specialists. And if we were to look more closely at primary care, we see even higher numbers. But so this was important for us to show the organization that this was leading to meaningful changes. So when we talk about meaningful changes, if we were to calculate the number of patients we see, approximately over 150,000 unique patients, how did the percentage increase in mammogram affect people? So we had about 9,000 additional mammograms that were performed or reviewed. And when we look at the data from cancer screening statistics, this would have been 18 women's lives that were saved from dying of breast cancer. What impact did it have on pneumococcal diseases? So we had approximately 11,400 additional pneumococcal vaccinations provided or reviewed, and this prevents 11 cases of pneumonia or 5 cases of invasive pneumococcal disease per year. And we had over 31,000 colon cancer screenings, again, reviewed or documented to ensure they were timely. And this, when you look at the national cancer statistics, would be 39 lives saved from colon cancer. So this is what it's really about, to make sure that the process that we invest our time and energy and actually have meaningful impacts on patients. And certainly, it's important that in doing good work, we're also solvent in doing so. So here's our projected return on investment over 5 years. So now that we've hit the exceptional performance range, from MACRA, we're over the next 5 years taking the increasing percentage at risk, avoiding about $27 million in penalties for our organization, and we have approximately $17.5 million of possible savings. This assumes just a 1% savings on the Medicare Shared Savings Program. Using an at-risk analysis looking at employee plans, if we didn't hit these quality measures at this performance level, we could be losing up to $7.3 million in potential savings. And there are, of course, just to estimate some of the costs associated with the diseases that that we presented, the prevention of 18 breast cancer deaths is approximately $7.7 million in savings over 5 years, and you can see it's even higher for colon cancer screening and pneumonia. So not only can one do good work, but it can also be financially smart to do so. So we are continuing to enhance the efficiency and the usefulness of the tools that you've seen. So, for example, we're now working and integrating in this, have already integrated in the state registry with vaccination information, so that that is auto-queried when our providers are doing their looking for their flu vaccine. So if it's already been provided anywhere in the state, that's automatically documented, and the provider doesn't have to do that. We're also using this technology to engage patients through pre-visit surveys and questionnaires, where we've had increasing dialogue and participation by our specialists, so we're optimizing the process for them so it's clear to them what role they have on which quality measures. Through that process, our specialists have identified that although they would feel comfortable with a certain subset, there might be some measures they are not so comfortable with. For example, a urologist might not feel comfortable ordering a colonoscopy or doing a mammogram, but when their quality measure flags, they know that that is a reason to send that patient back to their primary care doctor. And finally, as we all are having to keep up with changing measures year to year, so must we. So I want to end with a story that really shows the way in which technology, when leveraged appropriately, can have true human consequences. And when technology is implemented in a successful way, can really change the way that an organization takes care of patients and their community. So this is the story of a 59-year-old gentleman who actually, he's an athlete growing up and had recurrent knee pain and was following with one of our orthopedists in the system and was following up after surgery. And, after post-operatively, when the time was right, the orthopedist was checking quality measures and said, Mr. Jeffrey, I've seen you for a couple of times now, and every time that I see you, I notice that your quality measure alerts go off. He didn't say quite that, but he said, it looks like you've got a number of these, vaccinations and screenings that really need to be done. Do you have a primary care provider? Because of the education, the quality measure alert said, you're 59, you're 9 years past due for a colon cancer screening, and I have a family member who suffered from colon cancer, so I really think it's important for you to go see a primary care doctor. Mr. Jeffrey ended up coming to one of my residence clinics where I precept, and he was seen by the medical assistant who noted that the patient didn't have a colon cancer screening done by our PCMH care managers that go in to see new patients, who also reinforced that he hasn't had a colonoscopy done. And then my resident went in, and finally by the time I went in, he said, wow, that must be really important because every single person in the system has said, I need to get this done. Mr. Jeffrey did end up getting a colonoscopy a month or two after, and he was diagnosed with a local stage 2 colon cancer. Fortunately, it was caught early, it was excised, and he had some adjuvant chemotherapy, and he's doing well. However, had he delayed it, the story might have been completely different. And when I saw him in clinic just a month or two ago, he said that he's so thankful for unsuspecting primary care from an orthopedic surgeon. And that's the power that these tools can have and processes can have that cause an organization to row together to take care of patients together.
So with to Arnal for some closing statements.
Well, that was an awesome presentation and a great story at the end. I just want to remind folks where to go find this recording and more Davies case webinars and other information on how to apply for Davies Awards, which could be found at the HIMSS Davies Award website, hims.org/Davies. And once again, thank you so much